Thank you, Fiacre. I think that was fascinating presentation, and I think it's about, it's more transparency and engagement, and feeding back to the system and getting the system to come to us with any issues. So we're on to the final presentation of the day, and thanks to the adjustment later on or early on this morning with Lorna. So Ms. Jacqui Curley, who's again another person whose position has changed since this document was put together. Jacqui is now the interim head of HIPE and NPRS to replace Deirdre. So from tomorrow, I'm informed. So Jacqui's going to give us an update on the HIPE developments since the last conference. Thank you.
Hello, everybody. Now, my glasses have changed since the last time as well, so I'm very focals now since our last conference, so bear with me while I just get my reading abilities in place. Okay, so it's great to be here today, and it's great to see everybody in person, and I know there's people online as well, so it's just brilliant, and some new faces, and great to see our old pals around the system as well, so absolutely delighted. And it's a significant day for many reasons, and we've touched on a lot of them throughout the day, but it is our first conference since 2019. And HIPE really in that time has gone from strength to strength. I know we've all been in that COVID world, but really HIPE has come into its own over these last couple of years. And part of that is the recognition of all the work of the HIPE teams and the HPO and everybody involved in HIPE and all the HIPE data users as well. So it's just fantastic. Sorry, my slides. Okay, so I just wanted to set out just a couple of key pieces around where we are now. And HIPE is considered a strategic asset by the Department of Health. I know we're at the ABF conference, I know we're speaking about the ABF implementation plan today, but actually HIPE goes way beyond that. Way beyond that. ABF is one of the uses of HIPE data. So for those of you in the audience or listening online or watching this on a recorded video in years to come, your management and your leadership within the HIPE departments and within the HIPE service really stands to patients and how that data is used to manage, deliver, plan all those services for patients that rely on strong, timely, accurate data, which is what we always want with our HIPE data. So yes, we have a standardised system in place across all the acute hospitals. There's educated, trained HIPE clinical coders collecting that data. We're the envy of many systems because we have that in place. And it's actually the cornerstone of a lot of the systems that we've heard about today, earlier on. They're utilising that data. They're utilising that data. The HIPE system can respond effectively and very quickly. And I have a slide later on that will show you how quick we responded in terms of COVID. But also now this year we've adapted the system to collect a variable around the Ukrainian Temporary Protection Directive. So we have that coming through the system now. So the responsiveness of the system, our coverage and timeliness, it has been a real acknowledgement of the efforts of the system, that our 2021 file, we had to delay the closure till the end of May 2022, but we've 99.57% coverage for 2021 data, which given COVID, cyber attacks, everything else is just a credit to the system. There are pressures there, and I'll come on to that in my next slide. There are known issues with source documentation for coders and hospitals, and that is an international, I think Joanne would agree with me on that, that's an international issue with the type of information we're using as our source document. Medical information is not clean, it's not neat, it's not ones and zeros. That's our job as coders, to make it into something that can be used. So we face all those challenges with the handwriting, the results, the pathologies, the discharge summaries, the chart missing pages, things not filed, things not on the system. That's what HIPE coders really excel at. So when they're asking for your help as managers, when they're asking for your help and support from clinicians, that's what we need. We need help to make this system more efficient and that we can address those challenges going forward. And we are linking in with the clinical programs, and it was great to hear Mike's talk this morning. And you know, we can say the same things over and over again, but to hear it from the clinicians and to hear that clinical engagement piece is it's just great to hear it. So through the clinical programs, we have seen advances, and I don't know if anybody saw it, but we have the National Clinical Programme for Anaesthetics. Their report is out on the HIPE stand out there. They utilise HIPE data. It's making a difference in the quality of the anaesthetic information that's coming through. The sepsis programme, it's making huge differences in the work of that clinical programme as well. So it's a great approach for us to be able to link in with the clinical programmes. It won't solve everything, but it's great. The availability of the data for data users across the system. And again, that's another fantastic development that we've seen. Our HIPE data users training days that we run, clinicians, researchers, analysts, people all across the system who are using the data come in for training, and they get so much out of that day. They're engaged, they get to understand the data. We recommend they link in with their HIPE departments, their local HIPE experts in the hospitals. And it's through those data users that we build that message of why HIPE data is important. And we have the governance and the oversight of HIPE as well, around our HIPE governance group, which Deirdre chairs, the HICWA standards and health information, and the data is widely used. NICWAS, NOCA, it's widely used across the system. So that's fantastic, and that's why HIPE data really does matter for patients, the services, and the outcomes really. Okay, so we do have challenges. There are challenges in this system. The same system is in place across all the hospitals, but not all hospitals are the same. So what's an outpatient in one hospital will be a day case in another. What's admitted in one hospital will be a outpatient or a day case in another. So we're trying to just work with all those variances around the system. So things aren't always clear. We're dealing with big data. 1.7 million discharges in 2019, and it's gone down a little bit now, but we're still dealing with huge amounts of data and trying to identify what's happening in that data to get in there early, rectify things, see what's happening and understand it, and try and prevent that happening again in other areas of the system. I've mentioned our coverage already, but that demand for timely, accurate HIPE data is growing and growing and growing. And we have put in an escalation process now around coverage, because the issues to address coverage and chronic coverage problems often lie with the management rather than within the HIPE department itself. So again, I'm speaking to those who are leaders and managers and clinicians in the system about managing our coverage. Staffing of the HIPE function has always been challenging, but I think staffing in lots of areas in the health service is challenging now as well. But we have produced a HIPE Clinical Coders Resources Report, which is available on our website, and that's really useful, again, around structuring your HIPE department, having a career path, progression, the roles of the HIPE departments, the functions, and really making your HIPE department an attractive place to work, where that unique skill set is retained, supported, developed, and can grow, so that you're getting the best data that your hospital can get with well-trained, supported coders who are linked in with clinicians, linked in with the finance people, linked in with the analysts, all working together. Because unless you understand your HIPE data and the challenges they have, you're going to deal with those inaccuracies and the challenges around data quality, coverage. That's going to happen. So electronic healthcare records, hybrid healthcare records, that's another challenge for us. That's a world that is really happening now and growing. We have electronic healthcare records around the maternity system, fully electronic in some hospitals. We have a major teaching hospital in Dublin that is electronic healthcare record now. So that really is an area, and I said in a talk recently that we need to get smart about how HIPE operates in that environment. So that's something else that we do want to look at. But it is a challenge in the system, again, because we have to make sure every hospital is looked after in that system. Clinical support, we've mentioned already, the clarity of documentation and local supports in terms of dealing with documentation challenges. Where do your coders go if they are having really tough difficulties with coding cases? Are they spending mornings and hours and weeks trying to get things sorted out, or can it be sorted out, relatively easily? A little bit of communication might help. And we're also keeping our classification current, keeping it up to date with the system, our coding standards, keeping everything happening. We updated the classification in January 2020. That was our big job for 2020, was updating the classification. So that has happened, that was fine, but now we need to think about what happens next. From the 1st of July, tomorrow, Australia are updating to 12th edition of ICD 10am. So we're on 10th. So we need to think about when will we make that move to 12th edition? Is that the right thing to do? When will we do that? The lead-in time, getting everything in place. So that's something that we at the HPO need to consider when we're, in our next pieces of work in the short term. Now, there we go. Okay. So I'm just going to mention a little bit about HIPE and COVID-19, and this is just a really interesting timeline, and it's to give credit. I know we've spoken about COVID already today, but just to give credit to the coders collecting this data in the hospitals. On the 29th of February 2020, the first COVID case was announced in Ireland. We already had a code in place for COVID-19. We already had that from, I think, the 10th of February. On the 5th of March, sorry, my glasses now, 5th of March 2020, we had a request from the Department of Health for data on COVID-19. The 6th of March, we had draft proposals in place. 11th of March, we requested hospitals to prioritise the coding of COVID-19. In that space between the 6th and the 11th of March, we worked with a number of hospitals across the system to see what would work. We put suggested pathways, documented suggested pathways, and by the 13th of March 2020 we had that national system in place to gather COVID-19 data through the HIPE system. And it was a massive change because normally data comes into us on a monthly basis. This all changed to a nightly basis. Data came in every night. And there was a report available for the HSE, the Department of Health, all the groups that were looking at that data by 9 a.m. each morning. So HIPE coders who were going into work, I don't think were prioritised for PPE or anything like that, but they coded discharges, those COVID-19 discharges, within 48 hours or as close as possible to that discharge date. So it was absolutely fantastic. And it was like live data, demand for real-time data. Now, yes, it is provisional because it's subject to review. It was coming in so quickly, time to review and correct things or have a look at things. But there were so many analysts and our own teams and all the people looking at the data would come back to us with queries and questions. So there was really good engagement with the data. But one of the key pieces of that was around communication and support for HIPE staff. We heard a lot from them. We held query meetings every day. We prioritised the queries. So we really heard their voice. And I'm a bit conscious of that today as well, just around the importance of your voices in all of this work that we do. We really need your voice in all of this. So COVID is still happening. COVID is still happening. And over the time since 2020, we've had new codes, lots of new codes, guidance from WHO, from HIPE in Australia, and we also keep an eye on the international picture with that. And for those data users in the audience, the sequencing of the codes for COVID-19 means that the COVID-19 won't be sequenced as principal diagnosis, so it's just an important feature of the data to be aware of. We have a flag in Ireland for laboratory confirmed COVID-19, where the patient had that at any time in the past or present, and we brought that in October 2020, and that was kind of unique to Ireland, so we're proud of that one, but things have changed now a little bit with the antigen testing, but at the time that was lab confirmed COVID-19 was a key piece that we needed to know if the patient had that at any stage. I think I've mentioned most of that before. Yes, the data's monitored, analysed, reviewed, and we adapted our education and data quality activities to what we needed to make sure coders knew what was being asked for them. They had the guidance, they had response to the queries. We did lots of training sessions and education sessions with the coders as well. So, and they would ring us if something, you know, if they weren't sure of something, they would contact us straight away, which is fantastic. That direct line of communication is fantastic. Again, for those of you who might be interested in this, I just did a quick look at the data yesterday. So since 2020 to date, we have nearly 50,000 HIPE coded discharges for COVID-19 recorded, which is a huge amount of data that's there. It's available now for all analysis and reviews and to see what's happening in the hospitals. The top 5 DRGs I just picked out there, so you can see the majority of the cases we're going into as respiratory DRG with the major complexity, the E62A. And I had a look at the data. There's nearly 4,500 discharges with an ITU stay. So this is complex coding. This isn't just, you know, quick coding. These are discharges. Those ITU cases have an average length of stay of 32 days. So reading through patients' notes for 32 days is significant undertaking, and it does take time. So I certainly, and I think on behalf of the HPO, we'd like to acknowledge the work of everybody involved. So back to the present now. Back to the present. Just get my webpage here. So the ABF programme, the implementation plan, that's kind of our main work area at the moment. The actions for HIPE in the implementation plan are really in our main areas around data quality, education and awareness, and, as I say, the currency of the classification itself. So the review of HIPE that was started earlier on this year, I think, Brian, was it this year the review of HIPE started? Yeah, earlier on this year. So I think the engagements have been held for that. So that's a fantastic piece of work that's happening as well, to see where does HIPE sit in this huge healthcare world, where does HIPE sit, and you know, where does HIPE need to go. Our HIPE education post-COVID, and Marie Glynn, my colleague at the head of HIPE education, she would be very aware of the need to keep HIPE staff informed. So keep your eye on coding notes is what she said to me. Keep your eye on coding notes, and if you want to request regional training, and that's, I put up the little map of the hospital groups there, because we're very happy to go back out now and visit the hospitals if there's training you need, if there's some sort of audit or data quality activity that you need. We're very happy to go back out to the hospitals and arrange those now, subject to our availability. But we're very happy to be able to do that again. And the HIPE data users training is just great as well. It's really beneficial for data users and for us to have that link in to see what they need from the data. So the chart-based audit, we've recommenced those, so we're back out in the hospitals now. We aim to audit each ABF hospital once every 2 years, so we're hoping to get back on schedule with that now. But it's great engagement for us to see what's happening on the ground. And again, you can request a chart-based audit if there's something in particular that you'd like reviewed or looked at, or to engage with the HPO on. And I'm delighted today to launch a new look coding notes. So this is our newsletter out to the HIPE system, and we've a new look coding notes that we're delighted to launch. It has been it's a really important publication for anyone involved in HIPE or data users or managing the system, and we have an international readership, I can say. And Deirdre Murphy has been the editor of Coding Notes since it first started in 1998, and now that's moving over to Helen Nolan, who works with us in the HPO. So we want to thank the editors for this fantastic publication, and we have it up on the website today. It's available on the website, and I can do my... so for those of you who stay to the end of the day, we kept some copies so you can have. Now, I don't think we've one for everybody in the audience. So Deirdre has the first one. We gave Deirdre the first one, a signed copy. So yeah, you can get your autographed copy.
I've just seen it
No.
before we started. I'm delighted.
Yeah.
That was one of my big worries. Is what was going to happen to Corey?
And it's a really important document. Like it's a great, and they're all on the website, and the way that it has been developed over the years. But again, we love to hear from people, so whatever is happening, we're happy to put it into coding notes. But we'll have them on the HIPE stand outside. And I don't know if you saw, we have some laptops with the photographs from previous years up out there as well. So if any of you want to stop by for a minute or two, you can look at those old photographs as well. And so there's our contacts, and everything's available, including the new look coding notes and the ABF stakeholder survey, which is very important. Your voice, we need to hear that ringing in our ears. And just to say thanks to Deirdre, Maureen, happy retirement, and thanks for everything. Okay, thank you.